Thanks for tuning in to this special telemedicine edition of the Data Point podcast. This episode is one of several leading up to the annual meeting of the American Telemedicine Association in New Orleans, Louisiana on April 14th through 16th. Check out the conference. I think you're going to want to be there. And if you don't believe me, these next several episodes are going to try and prove it to you. Sometimes radical changes in our healthcare systems come as a result of a new technology, or a new drug or vaccine being discovered, or even a piece of legislation. But sometimes those big changes come as a result of a hurricane. Hello and welcome to Data Point, the podcast where we focus on all the ways that data and analytics are driving innovation in healthcare today. Our guest today is Dr. Karen DeSalvo. Dr. DeSalvo is an internal medicine physician in New Orleans, Louisiana. She's also spent a significant part of her career working in various roles within public health. At the federal level, she served as coordinator for health information technology, as well as being the Assistant Secretary for Health in the U.S. Department of Health and Human Services. Prior to her national government service, Dr. DeSalvo served as health commissioner for the city of New Orleans, and prior to that, she led the building of a high-quality primary care network serving the most vulnerable in the New Orleans community following Hurricane Katrina. On top of all that, she's a brilliant thinker and a lovely person. I know you're going to enjoy this conversation just as much as I did. Karen, thanks so much for being with us today on Data Point.
Oh, Greg, thanks for having me. I'm looking forward to the conversation.
As am I. One of the things that we like to do on the show, Karen, is in addition to talking about the work that you're doing, I like to give the listeners a little bit of context in terms of your background. How did you come to the point where you are today? I know that you've had some really, really interesting experiences in various levels of government and within industry and with, sort of paragovernmental organizations. There's a great story in there. I wonder if you could share a little bit of that with our listeners.
Sure. Well, I want to start with just something a little personal, which is that I grew up in Austin, Texas, in poor neighborhoods, and my dad left when I was young, and so my mom raised us by herself, and I was shaped and supported for that early part of my life by the really strong community and social infrastructure in Austin, Texas. It meant that I had access to good, safe public transportation and after-school programs at the Austin Recreation Department, and eventually good school system. We moved between 5th and 6th grade so that I could be in not just for me, but for my mom wanted all of us to be in a better school system. And that is embedded in me is this idea that even if you start with little, if you have a good community construct and ways to attend to the social drivers of your outcomes, it makes a big difference, and it really drives a lot of my thinking as a public health physician about not just helping a person, but thinking about making all the zip codes healthy. We have that zip code challenge in the country where it's a stronger determinant of your health and, frankly, your economic and other outcomes than sometimes what we think about things like your genetics. And I don't think any little girl ought to be struggling from that. We ought to be making it so that every zip code provides opportunity. And I think fast forwarding to where I spent most of my career, which is practicing clinical medicine. I'm an internist and practiced mostly in safety net environments like the Charity Hospital in New Orleans, and really learned a lot from my patients about how they had a lot of barriers to their wellness, and that all the great clinical medicine I could provide, or my team or colleagues, was going to kind of end at the doorway if they didn't have housing or educational or economic opportunity. And really think about them all the time when I was either making policy at the local or federal level, or the work that I do now, that it's not just those little girls, but whole families that are struggling with sometimes invisible things that we take for granted, those of us that don't struggle with those things. And I want to see that we create a world where there's a more level playing field so that people can really fulfill their all opportunity.
You know, one of the things that I read about your work, Karen, was in the aftermath of Hurricane Katrina and really helping to rethink the way primary care is delivered to some of those populations that were so dispossessed at that time and had been underserved for a long time. Can you talk a little bit about that work and how it shaped some of the things that you've been working on since then, at various levels of government and in other ways?
Yeah, that was already almost 13 years ago that we had that catastrophe of Hurricane Katrina, and it was a really transformational time for our whole community in the New Orleans area, and the health component of it. It was one of those moments in history when we took that time of catastrophe to find opportunity. And it's interesting, Greg. Even this many years later, I have this very visceral, deep memory of us, like, sort of, looking at each other and deciding that we were going to go forward as a community and do this together. And we were already so behind, from a health standpoint going into that storm, that I thought, oh, we can only go up. But of course, it could have gone much, much worse. So I just first want to make sure that it's clear to you and the listeners that our work here was a really community engaged effort that was multisectoral, but it also, I think, caused us to have to do a lot of rethinking about what we prioritized and how we were doing things like funding and paying for care. And we had essentially landed on a four-pronged approach to rebuilding the healthcare system in Louisiana that meant it would be grounded in primary care, that it would be digitized, so we would jump into electronic health records and interoperability. Third, that we would focus on value and quality in our payment models. And then finally, that we would expand coverage. And this was, back in 2005, before the country was really broadly moving in some of these directions. I will tell you that some 13 years later, we've made progress in all of those areas and achieved our goals. We built a really robust, sustainable primary care infrastructure in this area that serves about 200,000 people. And they're the same folks that used to sit in emergency rooms at Charity Hospital and other places and wait for care. And those sites are all, using electronic health records and on a regional health information exchange and improving in quality. And we've expanded coverage, and we did do some nice experiments with payment flexibility. We've got a little bit of that embedded. I still find that payment changes are going to be one of the hardest things for the country, but hopefully we'll get to talk a little more about that. It was, but I think so. The second was we had a very strategic approach, and we achieved all of it. And I think the third piece of this, though, was it wasn't quite that top down and structured. It was a lot more organic work, in which we created prototypes, and then we developed policy that was informed by those prototypes, and then could support the things that were good that were happening. And so, from a work standpoint and a policy standpoint, I'm a really firm believer that there is great benefit from having multisectoral interprofessional collaboration to solve problems, because you do better together. That you do need structure and strategy overall, and clear vision and goals. But on the other hand, I think you have to be willing to test and learn and iterate along the way, which is that third area of, like, literally creating the prototypes as we went and saying, no, that's not how you should do community health workers. They should be did this way, in terms of payment or structure.
Sure.
And I think that just drives a lot of the way I think about and do my work ever since. It was really formative for me.
It's really a remarkable thing, and you noted it, but I want to come back to this. The pillars that you talked about, a focus around primary care, making sure that everything is digitized, a focus on value and quality, and expanding coverage. All of this was happening before, the things that we think about today. We think about all those things as being sort of a part of our focus today, but this is, as you say, 13 years ago. This is pre-ACA, right? This is, predates, I think it predates the HITECH Act. Like, there are all kinds of interesting things that have happened since then that you all were working on earlier. And I think it is fascinating. You talk about the grassroots nature of that work. As you were going through that, were you at that point engaging people outside the traditional realm of the health system? were you beginning to address some of those social issues, that maybe were around housing or transportation or, some of the other things that we think about as social determinants of health today? Did those come into play as you were creating those and developing that framework for solution?
They did. And I want to mention a couple of examples of it. But first, I just want to say a word about the framework and the window of opportunity that we found ourselves in the middle of that disaster, which was, I had been practicing medicine, including primary care, in a really traditional environment at Charity Hospital, very doctor-centric, using paper, and had, over the course of time, had a variety of experiences of making good improvements within that framework. But when we were able to step out of that, because we were literally kicked out of the hospitals because they were closed and working on the street to create this new fabric, it just, the clarity around, well, the best evidence shows we can save the most lives, by increasing access to good primary care. And good primary care means that you can see what you're doing well and identify gaps, which means you've got to have digital information. It was really, for us, having seen our paper records turn into bricks when they flooded, there was no question that we were going to go back to that, right? So it was a really easy leap. And then we wanted to reward outcomes and value, and not blame patients or doctors for bad care, but really think about how you create a value-driven system that is enabled by systemness and not just by what one person does or thinks, and make sure everybody was in, like have a tent that had coverage expansion that everyone could be a part of. So just in that moment of clarity, I guess we dug into some of the same thinking and literature that has led to these other national efforts. And I think we really benefited from a lot of great national thinking in the space. So I just definitely want to acknowledge that what we were doing here on the ground, we very intentionally tried to inform that work from what really smart people who had done good work knew in other places. And that included thinking about the non-medical determinants of health. And it was really clear to me as a doctor that what my patients were often asking me about was not their medication regimen for their diabetes, but how they were going to get to go see their son in Angola how they could get off work in time to do that, and what was going to be the most effective bus route. Angola to prison here, and just sort of like very social services kinds of, or social work kinds of questions that I was ill-equipped to handle. And so I knew that these were challenges, and I'd done some research work that was published where we did qualitative and quantitative assessments of that. So it was on our mind. It was on my mind, certainly. And we did ask early on for CMS to support us in building models that would address the social determinants, not just the needs of individuals, but transportation systems, things that were more broad. And they flat out just told us, no, CMS does not pay for addressing the social determinants of health. Thanks for playing. Just ask again. And by the way, 13 years later, we have in the field a huge demonstration that CMS is doing to look at addressing the social determinants of health, the accountable health communities model. And that kind of a big shift in national policy, where 13 years ago it was just sort of thought of as the silliest idea ever, and now we're actually doing not just one, but about to start two other demonstrations out of CMS, is very exciting to me that our country can that quickly begin to conceptualize the multiple drivers of health and think about where and how we need to be making big investments to support, again, not only an individual, but to start thinking about making broad community change. And we found other ways to do that work here. We leveraged philanthropic dollars. And as part of our 3-year demonstration here, we did have population capitation payments that gave us very broad flexibility.
Interesting.
And allowed me as a clinic manager and leader to hire community health workers and legal and medical legal teams and provide transportation and food access. So we were doing all of that in our demonstration project. It's just that when that ended, like in many of those demos, even today, you go back to the regular payment system, which doesn't really support it yet. But I think we're making good progress as a country. But I will say this too, man, practicing medicine, when you know that if you ask somebody if they're going to bed hungry, you've got a way to address that, just frees up that communication with your patient, but also then you know that you're not sending them out into this, 99% of their time, which is going to feel really difficult, but rather you're going to be able to help them navigate a healthier life.
For what it's worth, Karen, I have just spent a few days at the South by Southwest Interactive Conference. And as you know, it has a pretty significant health track. And it's something I've been a part of for several years. But this year, the number one emergent trend that I saw at a macro level was this recognition that the social determinants of health need to be a primary focus for us. And so we saw a lot of discussions around system thinking and design thinking to help solve broader issues related to health. And I know, this is one interactive conference, but I think it does jive with the fact that, you mentioned that CMS is now running some pretty significant test beds to determine how we can more adequately address these things. And it's really showing up in all parts of the population, which I certainly find very encouraging. And that actually takes us to a good point for a break. We are going to be right back with Dr. Karen DeSalvo, so stick around.
Today's show is brought to you by BlueSpire, a full-service digital marketing agency focused on complex and highly regulated industries of healthcare, senior living, and financial services. Rapid changes in the healthcare industry are causing consumers to seek out trusted advice, demand more transparency and access to information and content. With over 30 years of healthcare experience, BlueSpire knows how to help you reach, communicate with, and gain trust from these consumers. We help you engage with the right content at every touch point, from the first symptom search to appointment scheduling through care management. Visit us at bluespiremarketing.com to learn how we can help you deliver relevant, engaging content through ever-changing touch points that matter.
All right, we are back. You are listening to Data Point. I'm your host, Greg Matthews, and our guest today is Karen DeSalvo. Karen, before the break, we were talking a little bit about some of the formative work that you were able to do in public health following the Katrina disaster. But later on, you were able to spend some time in Washington, interacting in policy at the highest levels of government. And I know one of the things that you mentioned pre-break was an interest in reforming payment models and how payment models were working, and how the private sector played into some of that payment flexibility that we were talking about. Can you give us a sense of some of your points of emphasis during your time in DC?
Definitely. The experience that I had as a doctor and health system leader and public health leader, all of those touch points just kept reminding me that much of the way that we were paying for care delivery was by the piece and not giving enough flexibility to the front line to deliver services that it needed to deliver to meet people where they were. In New Orleans, as an example, when our health system, plural, shut down and we were using mobile units and hacking together, this church is a good place to build a clinic. We really wanted to use tools like telehealth. And we tried with some of those earlier versions, and they weren't really ready for technological prime time, but it was just a reminder for us also, though, that if we were going to do, say, telehealth with a specialist who was in another community, they weren't going to get compensated for it. Right. And it was also sort of difficult in the workflow of the clinical team. But it stayed with me. And in fact, when I got to Washington, the first job I had there, I was the national coordinator for health information technology. And one of the first meetings that I had was with a team coming in to talk to us about telehealth and payment flexibility. And it led to a series of eye-opening conversations that I had, including things like we have about 30 some odd definitions of telehealth in the federal government, and not a lot of alignment about payment and what kind of technology should be used. And it drove a lot of us up there, as we were not thinking only about the sort of technology components of healthcare, but when we were doing our delivery system reform work to develop new payment models, was that the more flexible we could make the payment model and not be so specific about the when and where and the how care gets delivered, but allow providers to meet patients where they are, and do so with appropriate accountability and oversight that just in the way we had in that 3-year demonstration in New Orleans, but take that really to scale, that you could do things like telehealth if that made the most sense for folks, and kind of break that kind of federal mindset that telehealth is a tool for, say, rural populations, which I knew firsthand. It was also a great tool for urban populations and people who are incarcerated. There's all these other, reasons that you might want to use it, all these other additional populations, and we needed to get our mind out of the service-specific component and move to a broader, flexible care and outcomes kind of model.
And how did you begin to tackle that throughout your time, working in central policy circles? How did that begin, and where have you seen it evolve now? For our listeners who are less familiar with reimbursement models, maybe give us a sense of where we are today and how we got here, where perhaps you think some of the next steps are in terms of freeing up the reimbursement to be able to provide care in line with the way that those frontline clinicians you referenced believe is best.
Mm-hmm. So I think there's at least 3 things happening concurrently, and one is policy, one is the technology, and the third is the consumer expectation. The policy component has rapidly evolved since I started in the federal world in January of 2014 until now, some 5 years later. It between actions from Congress and actions in HHS, there's been a lot of movement to allow for providers to deliver care in many formats, not just one-on-one doctor-patient visit. And in some areas where there's more flexibility, like in Medicare Advantage, there's been more latitude given. I think there's been more acceptance that inside of other accountable entities, so Medicare Advantage being one kind of accountable entity responsible for the total cost of care. Sorry to get all wonky, but accountable care organizations are similar kind of financial and delivery construct. And inside of those models, we're seeing a lot more ACO and those organizations delivering care through platforms like telehealth or asynchronously using data. So we're seeing that care systems that are given more flexibility through payment models, some in demonstration and some that are more mainstreamed, that naturally starts to emerge. And it's getting easier to do that for populations that are, say, seniors or folks that are at work and don't want to, leave their desk or leave the line, for kids in school. There's a lot of ways that we're recognizing that telehealth and telemedicine can, and I use those 2 things distinctly, that they can be a valuable tool for providers, and really just so instead of getting more focused on how to pay for what when, to really just say the goal is that the diabetes is controlled, or that the asthma is controlled, or that people stay well more generally, and that we're seeing the policy supporting the providers and doing the work. The second area is about the technology, and back when this was introduced as a care delivery tool to us after Katrina in 2005, it was a hardware system on a rolling cart that we had to lock in a closet. I mean, everybody, it's sort of ridiculous. Like, you're not going to go whip that thing out when you're in the middle of a really busy clinic. It's very difficult when it's not part of the workflow. But if you think about how dramatically the world has changed, and it's on our smartphones, which are not ubiquitous yet, but getting there. And I think technologically, between Dell communication and ongoing advances in broadband, not reaching, Appalachia and everywhere that we want in the country, but I think we're going to get there. We're going to have the underpinning, the cellular and broadband and other underpinning that will allow lighter tools like smartphones to carry that information and make it more accessible to people. And there's other opportunities there around documenting what happened in the encounter using natural language processing and storing that information, because now we have cloud-based storage. So it's just technologically getting more feasible to do as a regular course of business. So it's not really a regular course of business, and that kind of brings me to the consumer. Though consumers are pulling it, and I think we see, millennials or those that are covered on some of the health plans, that's like an Oscar in that vein, are accustomed to that kind of digital communication with others. Maybe not as much for all consumers, but I think that pull is going to get stronger and stronger as people realize that a great deal of medicine can be done without the human touch, especially chronic disease follow-ups and things that maybe rely more on labs or maybe some of the initial assessments. And so I expect there will be more pull, just as the policy is enabling it and the technology is as well. I think there's going to be a little more pull. I think the pull will also come from employers, and as they begin to recognize that there's some other opportunities. I think what we miss, and there's maybe a couple of key things. One is clinically. I know I can do a lot of medicine by video and by phone and by email, but there's a lot of stuff I cannot do. And
Sure.
I don't mean just listening to someone's heart. I mean, touching somebody, being in the room with them, it creates a human connection that causes them to tell you things they may not otherwise have told you that really matter for the way you're going to prescribe and treat or diagnose and treat. It also, I think there's a lot to the healing touch that sounds a little woo-like, but it does seem to matter that people are touched, and that I think one of the other potential downsides that concerns me, which is particularly in seniors, that we aggravate social isolation by doing a lot of care for them in their home, and they don't have as much human-to-human contact. So I think there's a lot of good. It's more enabled. People are more interested in it. I just want us to begin to already start thinking about what are we missing, right? What are the potential downsides? And can't do it all using that delivery mode, but I do think it'll really free people up and hopefully make care more affordable and more efficient.
And one of the things that I've talked to a number of people about leading into the American Telemedicine Association's annual meeting is the fact that if we are limiting the role of telehealth in terms of just replacing a face-to-face visit, we're really, really missing the mark. And I think that it plays exactly to your point that this is a tool in the toolbox. It is a part of the care continuum. It does not replace face-to-face or human-to-human connections, if I'm paraphrasing you correctly.
Mm-hmm. Mm-hmm. I think that's true. The little you heard me make is that what I do want to be careful about is that we don't add a new point of contact, a new service that we can charge a fee for. Because that's the last thing the healthcare system needs to do to itself is drive up costs. And so far there's a little bit of indication that's kind of what's happening because we haven't quite, this goes back to payment flexibility. We haven't said, you're still going to get paid for doing this work, or it's going to be built in, let's take primary care, built into the global capitation that you're going to have. And you don't have to worry about the sort of for the piecework. I think it's also the challenges about documenting what happened in the encounter. And as we get better with that technologically, I think this is always the problem, even with telephone medicine. I wouldn't always do as good of a job as I needed to. And I think most docs would say that, or after hours nurse call lines, of documenting exactly everything that happened. So we've got to be meticulous about it and treat it, like a visit so that we can have a record and remember what happened and be able to have continuity for the next visit. But I do think also, by the way, we're just beginning to understand the power of telehealth for B2B communication, for doctor to doctor or hospital to hospital, or for enabling really specialized services to happen. And that starts to change the thinking around network adequacy for health plans. And, you need to have a dermatologist. Do they have to be in that zip code or that town if they're going to be the best dermatologist or the best pathologist or the best whatever? I think we also need to start freeing up our brain around how this liberates geography, liberates from the sort of geographic underpinnings that we've had in medicine for a long time.
Yeah, I read a news article that popped up this week about kind of a really unfortunate situation where a patient had been recommended by his initial treating physician to have back surgery, but ultimately was able to get a telehealth consult from a specialist, and ultimately wound up being diagnosed with Parkinson's disease. And that's obviously an outlier kind of situation, but I think it speaks to what you're talking about in terms of being able to access the right resource for the case, even if they're not necessarily sitting next door. I'm curious about, have you seen examples, either in industry or through some of the test or pilot work that you've done through government plans? Have you seen any instances where you feel like that concept has begun to prove itself out, or has even been tested at scale?
I haven't yet. I think that the closest that we would come to it so far is what the VA has been able to do.
Okay.
And part of the reason that the Veterans Administration has so much latitude is because they're not bound. First of all, they have a global budget, so they have very flexible payment by and large. Where technology might be lacking for a veteran, they're able to provide it, so they don't have stark issues around things like inducement that sometimes can get in the way. They also don't have health professional licensure restrictions in the sense of crossing state boundaries, because they're working on federal property, and they've been making some additional moves to free that up. And so there's these other things that can bind up the private sector. Now, that said, Kaiser Permanente, I believe they're at a point now where more than half the primary care visits are virtual. I don't know the statistics on their specialty care visits, but I could imagine a big national system kind of structured and built a little bit like the Veterans Administration, because Kaiser has got some similarities in terms of their budget and payment and technology capabilities, that they would be a good place to look for additional resources. If I ran a big business, if I ran Comcast or something like that, I would be extremely interested in driving this agenda, because I want my employees to have center of excellence level treatment for everything. And I wouldn't want it to just be the way it is now, where you get a second opinion on paper, but for it to actually be able to incorporate real-time conversations between the clinicians, but also to include patients and families.
Yeah. And, it's interesting. I think that we're seeing that beginning to crop up. I can say even this week, I've talked to a small businessman here in Austin who, as he was constructing his benefit system for his employees, again, this is a small business based in Austin, he's not only made it optional or available, but he's made it mandatory for employees to get a telehealth second opinion from a nationally recognized expert before doing any kind of surgical procedure, which is a really, really interesting thing. And if that starts to happen at scale, you're right, it is really going to shake things up, from a network perspective, and frankly, from a traditional continuum of care perspective, I think.
Yeah, I don't know if you're going to go to this whole conversation about disruptors, but I'm going to go there.
Let's do it.
I guess as I think about what an employer wants or what a consumer wants in the future, we have come to know that it is possible to be more preemptive or anticipatory about our needs in other sectors, and to help guide us to the best value or the lowest price or the most accessible of just about anything. Flights, trains, shoes, you name it. And we haven't really leveraged that yet for a bunch of reasons in healthcare. And I get really excited about the kind of work, for example, that a CVS is doing, where they're already providing telehealth consultations as a part of that new business line that they're doing, and thinking about meeting people where they are, not just at a neighborhood drugstore, but online as well, and being as preemptive as possible. Similarly, I think the increasing availability of things like smart speakers in our homes means that we're going to be able to, if we allowed it, be listened to, and it would start to share information with us about, you see your back's hurting, you might think about this as a resource first, as opposed to sending you straight to the surgeon.
Right.
And more intentionally, just asking the question. I'm having back pain, or I'm thinking about going to see a surgeon, and you could build into a system like that. Well, typically typically you want to first see physical medicine and rehab, or internal medicine, or whatever you want to encourage as the best evidence-based line of care, and make it easy. Help make the appointments then and there. Oh, I see that you're see that you're in town this week based on your calendar, and that you have an opening, and there's an opening at this internal medicine doc, and they're only this far away, and the bus will get you there. And you would think that that's for rich people, but you may have seen the news article that Molina, which is a provider of Medicaid services, has just announced that they're going to make Amazon Prime membership available to their beneficiaries as a test to see if they can start to leverage that kind of smart system to link people with healthier food and with transportation and other resources. So I think that's great, because you got to build equity in from the front, especially for people who may not naturally right now have smartphones, et cetera. We got to make sure the technology doesn't prevent them from being their healthiest self. But I think we're just beginning to understand how the digital world is going to enable better decision making, more accessibility, especially to things that are evidence-based. And I think there's a world in which we also start to turn those smart speaker kind of conversations that right now are a little bit flat, though they're building their augmented intelligence to make the clinical conversations more robust. You could easily turn that into a visual conversation. And it could be with a real provider, or it could be with a virtual provider.
Wow.
And so I think the healthcare system needs to pay a lot of attention to that, because it's technologically nearly feasible. I think it's clinically getting some legs, because we're getting better at augmented intelligence, and we're recognizing it's not a supplantation, but it's a support. And people, frankly, respond to it. They like the preemptive and proactive nature of the way their lives are supported and encouraged in other sectors. And I think the more they get a taste of that in medicine, the more they're going to want.
And boy, what a fantastic kind of cliffhanger to leave us with, Karen. I want to encourage all of our listeners who are getting as fired up as I am listening to this conversation. Both Karen and I are going to be speaking at the American Telemedicine Association in New Orleans, your home city. April 14th through 16th. And so I would strongly encourage you, if you have an interest in being a part of that, to go out and register, to meet us there, and to continue this dialogue. Karen, I am so appreciative of you sharing your time and your thinking with us. Thank you for all the amazing work that you've done in public health throughout the years. It's something that I think just about every American is benefiting from at some level, and we really appreciate it.
Well, thank you so much. That means a lot. And thank you so much for taking the time to chat, and really looking forward to having everybody come to New Orleans for ATA. It's going to be a great meeting, and I'm looking forward to all the dialogue.
Thanks so much for listening to the Data Point podcast. If you like what you've heard, please do rate, review, and share it with your social network. It means a lot. And if you have ideas for show topics or guests, please email them to me at greg@healthquant.health, or send a direct message to @ChiMoose on Twitter. That's CHIMOOSE on Twitter. For more information about this show or any of the terrific healthcare podcasts in the Touchpoint Media Network, check them out at touchpoint.health. See you next time.
This has been a Touchpoint Media production. To learn more about this show and others like it, please visit us online at touchpoint.health.